I don't see the thing up here. There we go. All right. I think we're probably good time-wise. We can get started. Looks like we have enough folks in here ready to get going. You got me here to share screen, Dave? Yeah, it looks like I'm good. Okay. All right. Seeing this? Yeah? Okay, good. All right. So last week, we spent essentially the whole hour here going over the anatomy stuff. Now, today, I wanted to make sure we get through at least the biomechanics component. There's only a handful of slides that we're going to have to deal with here. Now, there's a fair amount of talking that goes involved with all of these different slides. But I want to make sure, do we have any burning questions about any of the anatomical stuff that we went over last week? I know, like I said, a lot of stuff. The way we view the thorax tends to be a little bit different than the way people have been taught it in PT school and other anatomy classes. We tend to break these things up into various functional regions, CT junction, mid-thorax, TL junction, based on how it's going to function for us, right? So TL junction is really a gating mechanism, allowing forces that are distributed from the lower limb during tasks like striding, gait, during things like standing axial rotation, those sort of things, where we have to be able to transmit these torsional loads through the thoracolumbar junction and into the rib cage, where a lot of these forces can be dispersed. So many joints in the thorax, including that sometimes when we do these counts, it's 135, 134 different joints, depends on if we're including the interchondral joints, but a lot of ability for us to disperse forces through a very flexible structure here. So that's a good thing. It tends to be something that makes us very efficient. We'll talk a little bit about efficiency of motion as we get down toward the end of the stuff that we have, the slides that we have for today. But if nobody has any questions about the stuff that we went over for the anatomical components, we can get into the biomechanics of it. Anything? Anybody? Dave, any questions? Stuff you need me to clarify for you? Okay, good. All right, so the biomechanics, I do tend to subscribe to Diane Lee's thought processes when we're talking about the biomechanics. I think Dave does as well, very notably. I think that's a lot of what we have in the course materials that we've presented for you guys. But it seems to me to be relatively simple. If we're looking at the biomechanics here, these components, we're talking about the vertebral biomechanics at this point. We're not terribly concerned with the ribs just yet. We'll get into that here in a minute. But these should be pretty simple. If we're looking at flexion, so if we bend the trunk forward, what we should get is we should get an anterior roll of the vertebral body along with a superior glide of the facets, right? So we're talking about, if we're looking at T5 on T6, the inferior facets, which are the facets on the bottom of T5, right? These are the ones that are going to then overlie, right? So if we're looking at T5's inferior facet, T6's superior facet, they should rest like this, with that direction facing to my left being the anterior portion of the vertebra. So we're going to get a superior glide, superior and anterior glide of the inferior articular facets, along with an anterior roll of the vertebra itself, right? So this is going to produce something of an anterior translation, an anterior roll of the vertebral body. Should be pretty simple, very similar to what we saw in the lumbar spine, what we see in the cervical spine as well. Extension then is essentially just the opposite of that. We should get a posterior roll of the vertebral body with an inferior and posterior glide of the inferior facets. Now, you'll hear us use the terms IMP and SAL quite a bit during biomechanical analyses. So IMP is associated with extension. That's an inferior, medial, and posterior glide. Typically, those medial glides that are associated with that are going to be associated with unilateral movement. So we think about those things when we're doing PIVMs and PAVMs. Essentially, we're looking at unilateral movement of one particular facet. So say the right-sided facet of T5-6. When we're doing bilateral movements here, or symmetrical movements with flexion and extension, it's really going to be much more of just an inferior and posterior glide, and then an anterior and superior glide. Okay, so that's essentially some of the terminology you'll hear us use when we're talking about facet joint movement that's associated with these sort of things. Side bending, again, this is relatively simple. It tends to get a little more complicated when we start considering the ribs. But the idea here with side bending is we're just getting a flexion moment on one side, on the contralateral side, and then a extension moment on the ipsilateral side. So when we're talking about facet joint movement, if I'm going to side bend to my right side here, I should get an inferior and posterior glide. This will actually have more of that medial glide as well. Inferior, medial, and posterior glide of one side, the ipsilateral side, superior, anterior, and lateral glide of the contralateral facet joints. Okay, so essentially we're just getting reciprocating movements from one side to the other here during side bending. The way that it does become a little more complex here is when we have to start considering the articulations of the ribs. So because the ribs have the demifacets that articulate in between the two vertebral segments, so there is actually an association with both the superior segment and the inferior segment, along with the intervertebral disc, it produces a moment that's very similar to an uncinate joint, right? To an uncovertebral joint in the neck, where there is an opposite side translation of the vertebral body relative to its midline. Okay, so if I'm going to produce a side bending moment to my right side like this, what I should get then is a left translation of the vertebral body. And now this should happen sequentially as we move downward. So that should produce, relatively speaking, a scoliotic curve, right, or a side bending curvature of the thorax, if we can do this in a straight coronal plane. Okay, so that does become important because we can have translational lesions of the thoracic spine segments, okay, which is more common than you tend to think, because speaking from personal experience, when I first learned of translational lesions in the thorax, it was during a course similar to this. It was during my fellowship training and some of my certification trainings, and I had never heard of such a thing in the thorax leading up to that. So coming out of school, I just had no clue that such a thing existed. Probably part of the reason that I was so frustrated and wanted to stay the hell away from treating the thorax to begin with, because I didn't completely understand what the mechanics were like, and how these mechanics can actually affect the thorax and create pathology that we are capable of correcting. Okay, so very important to understand that translational lesions are possible, and there are clusters of movement tests that we can do to tell us whether we have a translational lesion, a facet lesion, or a rib lesion. Okay, translational lesions, whether it's a lateral translation, meaning side-to-side translation, or an anterior translation, we tend to call ring lesions, R-I-N-G. So that's one type of lesion that we can have with this. We can also have facet lesions, which tend to be much simpler. And then we can also have rib lesions, R-I-B lesions. Those are kind of the three basic mechanical problems that we can assess for and treat for in the thorax. But there are kind of clusters of movement tests that we can do that should be able to tell us whether it is one of those versus the others. And it tends to be very useful. Do you have something there, Dave?
Yeah, no, I mean, it may seem confusing at first, but then once you get the biomechanics of it, it won't seem nearly as confusing. Like, let's say, like the flexion subluxation or the anterior subluxation. I mean, who's the patient you typically see that on, Eric?
Well, we see it a lot in shoulder patients.
Mm-hmm.
We see it a lot
Yeah,
in neck patients. We see it a lot in patients with headaches, things like that. Patients that have forward head posture will
yeah,
tend to have a very notable anterior subluxation of one of the thoracic segments. It tends to
yeah,
hold them in that forward flex position.
yeah. You get that thoracic segment, which is just stuck anteriorly. And then we talked a little bit about in the cervical course that, if you don't correct that segment in thoracic spine, then you can do chin tucks from now to the cows come home. It's like nothing in the neurophys system is going to change
Yeah.
because of that segment that's been stuck trying to translate it in a flexed position. So if you get stuck in that flexed position, there's several millimeters of anterior translation. And those are the ones that when you manipulate them, they're like, those in the transversal, they just clunk. It's
Yeah.
like it's very audible, palpable. It's different than like a facet joint or the unilateral or rib joint. They'll click or pop, but those are the ones you generally always hear about.
Yeah. And the problem sometimes when you're doing some of these techniques, like if we're looking at an anterior translation, so we have two vertebral
Mm-hmm.
segments sitting on top of the other, and we get this segment that's kind of shifted forward. When we correct that, we're trying to do some sort of traction technique or a distraction and posterior translation type of technique. And we'll show you probably half a
Mm-hmm.
dozen different ways of doing that. Maybe not quite that many, maybe five, but at the same time, when we do those sort of things, we'll get multiple cavitations with this because it's almost impossible to do a technique to the intervertebral
Mm-hmm.
articulation without also gapping or cavitating the facet joints posteriorly. So that's sometimes one of the ones where we'll get the clunk 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 or the pop pop and then the big clunk that comes after the fact. Um, Perfectly normal. There's no in a healthy joint, there's no harm that can be done. I emphasize healthy joint, healthy segment, that harm that can be done by gapping the facet joints before getting the treatment to the actual
Yeah.
vertebral segment. So that will happen. It's almost inevitable, especially for some male therapists that have really big meat hook hands like I've got. It's difficult to get super specific in some of those instances, but it's all right as long as you're comfortable with the integrity of the segment as a whole. There's no reason that you can't have all of those things happening at once, because essentially a gapping technique, especially for the facet joints, is very benign.
Yeah, I
In
mean, and you're going to use that for the two you're probably most confused about right now, which would be the anterior translation or the flexion kind of lesion or the rotational lesion. You know.
and the flexion lesions, like I said, they tend to be caused by forward. They tend to be affected by
Mhm.
forward head posture, but they can also then perpetuate forward head posture, right? It makes it impossible to get the chin back over the breastplate because it's constantly pushing us forward. So it constantly puts our chin out in front of our line of gravity. What tends to happen is, and the way I've always viewed this sort of thing is when we have a situation where, say, we have a patient that's sitting at a computer and they're in this forward head position constantly, is we're essentially hanging on the cervicothoracic extensors. So we're talking about the splenius cervicis, splenius capitis, the semispinalis, these sort of muscles where these things are connected to the thoracic segments, but also attached to the neck. And so we're getting this relative anterior translation of the vertebra, but now we're also getting this posterior vector where all these muscles are pulling from behind. And so what we'll get is we'll get a situation where the segment will shift anteriorly, but it'll produce an extension moment at the same time. So now we have an incongruent movement that's occurred through that thoracic segment, and it's just stuck. Once that happens and we get this extension moment with an anterior translation, that thing is not going to be able to self-correct on its own at least not very likely, or very commonly. So we have to produce some sort of traction technique and posterior vector in order to get that to seat back more effectively. Once that happens, though, it's going to constantly push that chin forward. It's very much going to start to perpetuate some of those forward head postures. So when you have patients that come in with postural dysfunctions, or they're coming in with headaches, or they're coming in with retroorbital pain, or pain in the temporal region, or even issues over the ears. I mean, we can talk about the different reference patterns that we can have for these sort of things all day long. But you're doing work on the CV region, you're doing work on their neck. You're trying to get these things corrected, but it just doesn't seem to get over the hump with that. A lot of times these flexion subluxations, these anterior translational subluxations, can be the primary reason why it's not correcting, or at least not getting as the results that you're hoping for. Right? There's still some lingering problems. They have to stay very on top of their exercise stuff. They spend all kinds of time doing chin tucks and doing various types of
Mhm.
postural exercises and things of that sort of nature, and it just doesn't seem to be given the result that you want it to. A lot of times it is this sort of incongruent thoracic subluxation that's causing that to be perpetuated. So that's another issue. You probably see that quite a bit too, right, Dave?
Oh yeah, I mean, as we said, the thoracic spine is I treat a lot. You're always up in the thoracic spine,
Yeah.
cervical patient, lumbar patient, somewhere in there. I'm in the thoracic spine, any shoulder patient.
Yeah.
It's hard to get away from. At some points, even I'll get as far as looking at it from in the lower quarter as well. Is there a vector from the thoracic spine that's not moving well? It's impacting gait or movement below.
Sure. Yep. Happens a lot.
And how about the rotary lesion? What's the rotary lesion? I certainly I see lacrosse players, I see tennis players, so I see the rotary one being caused many times by just how these forces kind of get wound up in these individuals. Or it can
Yeah.
even be that individual that sits at a desk and they're slightly off center. Working a little bit to the right or the left.
Yeah. Well, and we also have the duality of man that we deal with nowadays, where we have patients that will sit at a desk all day and then they want to go play pickleball after work, right? And so now we've gone from a flexed sedentary posture all day, 8, 9, 10 hours, sometimes more than some of my population. And then now they want to go do a very upright, very dynamic, rotational based activity. And it's just a question of whether or not the body can produce that sort of movement after all that time, right? And so we'll get these kind of traumatic or semi-traumatic type of rotational lesions that can occur not only in the thorax but also in the lumbar spine, as a result of limitations through the thorax, right? If we can't rotate, most of our trunk rotation, we were talking about this last week on the anatomy section, most of the rotation of the trunk should be coming from the thorax, right? If we can't rotate through the thorax, we got to make up for that loss of movement somewhere. And the lumbar spine and pelvis in particular, tend to be the areas where we'll make up for that sort of thing for the trunk, right? This is taking the hips out of consideration because it's not technically part of the trunk; it's more part of the lower quadrant. But we can have very easily have issues with the lumbar spine due to damage there. Because the lumbar spine, like we mentioned, it's not designed to rotate. It's in fact very much specifically designed to resist rotation. There's a slide here later on talking about efficiency of movement and the ability of the body to build up torsional forces, right? And the idea here is to spring into certain movements, where the lumbar spine is very good at doing that because the joints, they face straight forward and back like this, right? So one half runs into its counterpart, the other side will gap open, so it creates this very kind of twisted spring. And so when we come out of that sort of situation, it will bounce back at us, and so it adds energy into our system. If you think of I have actually multiple images that I use for my rotational athlete course. We're talking about how athletes will twist themselves up. If you think of a golfer or a baseball player swinging a bat, where they go into this loading phase and they twist themselves, where they have their shoulders moving in one direction. So if I'm going to swing this way, I'm going to load my shoulders this way as I open my hips and take a stride forward. And then when I release that spring, it adds energy into the system. So we'll talk more about that as we get to it. But again, you can kind of see when we're doing things like that, how easy it would be if we can't produce those rotational movements through the thorax, how things like the lumbar spine, because it's sitting right in between the two, the lower extremity and the thorax, it's very easy to beat that region up. You see that a lot. Any questions here about these biomechanics? Rotation, I don't think I even mentioned it, but very similar to side bending, we'll get a superior glide of the opposite side facet, right? So superior, anterior, and lateral, and then inferior, medial, and posterior on the ipsilateral side. And we're going to still get that opposite side translation of the vertebral body relative to the articulations with the ribs. Okay, now here we come with the ribs. This is typically, at least in my experience, this is where people start to panic when it comes to the biomechanics of the thorax, because the ribs, they just sound very complicated. They don't have to be. realistically, there's a couple of movements that occur with the ribs that we get very specific on that we can look for, and that should tell us whether or not we have a rib lesion. And again, I'll talk about that as we get going forward. But looking at it in relationship to movement of the trunk here, these mechanics that we're discussing here on this slide are not related to inspiration, expiration. They're related to the same sort of cardinal plane movements that we produce with the trunk. So flexion, if we are to roll forward, superior segment is going to produce that anterior roll. And what that's going to do is the demifacet on the inferior half of that superior segment. So again, if we're looking at T5 moving on T6, we're looking at T5 rolling forward on T6. That demifacet on the bottom half of T5 is going to pull the head of the rib into an anterior rotation. So essentially what that means is the entire ring is going to tip forward, just like this, right? That should seem, relatively speaking, kind of intuitive. At least I think it should seem relatively intuitive, okay? Extension is basically the exact opposite, just like we were talking about with just the vertebral movement, right? So as the superior segment, as that T5 rolls posteriorly, that same demifacet on the bottom half of T5 is now it's going to push that rib into a posterior rotation. So essentially when we go into extension, we should see the whole segment roll posteriorly just like that. Okay. Side bending, again, side bending to me is where it tends to get just a little more complicated. And the reason for that is just this first sentence here. So the motion of the vertebra will exceed that of the rib. Okay, so the rib joints don't move quite as much as the vertebral joints will, and that's why this kind of oddity of biomechanical movement will occur. So as we move into side flexion, right? So I'm side bending down to my right side. The right side ribs, the rib angles here on the lateral margin will approximate. And that's essentially going to stop their movement eventually, right? As soon as that space in between, that intercostal space, is closed down, ribs are going to stop moving. The vertebra, however, is going to continue to move into side bending slightly. So it has a little bit of extra excursion that occurs after the ribs have stopped. The only way that's possible is as the rib continues to side bend, it has to rotate contralaterally in order to make that movement continue. Okay, so when that happens, what it does is it produces a contralaterally coupled moment. So what that implies is that the ring will side bend to the right, and then it will rotate to the left. Okay, or vice versa, side bend to the left and rotate to the right. What that will do for us then with the ribs is if I'm side bending to the right, it will actually rotate the right rib into an anterior rotation and the left rib into a posterior rotation. So it's going to follow that kind of rotary moment. As we side bend here, it's going to rotate the opposite direction and look toward my left side. There is a term for this sort of thing that we look at. It's called latection. So it's a moment that's instigated by lateral side bending or side flexion, but then it is coupled with this contralateral rotation. Very important because it is one of the best ways for us to diagnose translational lesions or ring lesions is by using these sort of combined moments. Okay. When we get into rotation, okay, so a movement that's instigated by a rotary movement turning to one side. For the ribs, this moment is primarily occurring along the lines of the costotransverse joint, right? So if we have a vertebral segment like this and we have a transverse process and the rib comes in and articulates like so, where we have the costovertebral joint and then the costotransverse joint, these moments occur like this along that plane. Okay, so we will get a posterior and lateral glide or an anterior and medial glide. Okay, so with rotation, relatively, the way I think about this is I'm getting the vertebra is spinning in between the rib cage. So again, if I'm sitting in this sort of position like this, and I want to rotate to the right, right? So if I'm rotating in this direction, what will happen is the vertebra will rotate relative to the rib, right? And so this produces a lateral glide of the transverse process, or relatively an anterior and medial glide of the rib itself. Okay, now if I'm going the opposite direction, and now I'm rotating to the left side here, we're going to get this sort of moment where the vertebra is rotating here. And again, it's going to look more like a posterior and lateral glide along the line of the costotransverse joint. It sounds like a very complex situation, but it's really not, right? So if I turn to my right side, the right ribs, the right costotransverse joints are going anterior and medial, and the left costotransverse joints are going posterior and lateral. And we should be able to appreciate that. If I turn this way, the rib cage on the right side is going to compress, which would go along with that anterior and medial glide as it kind of compresses that space. And the rib cage on the left side and the contralateral side is going to expand, which will go along with that posterior and lateral motion. Okay, so I think it's relatively intuitive to kind of understand that moment. So if I have a rib lesion, for instance, on my right side, I have an inability of, say, my sixth rib to produce an anterior and medial glide. It's going to limit my ability to turn to my right side, because I should be getting that anterior medial glide through that level. But if I can't do it, it's just going to lock me right up as I do that. If, however, I have a loss of posterior lateral glide on the left side, it would still limit my ability to turn to the right, if that makes sense, because I should be getting that posterior and lateral glide on the contralateral side. So again, we will go through these things very specifically during lab in order to show you guys how to assess for these sort of problems. But it's important that we understand these mechanics ahead of time so that we can be aware of what we need to look for. Do we have any questions about those two things? Anything you want to add, Dave? You're muted. Sure, it was a poignant thought, but we couldn't hear it.
It was my best one. Now it's lost. It's, you think about your patients who have that, the unilateral pain, thoracic spine with rotation or motion. Once we're down there and hey, when I'm rotating to the right, I'm getting this biting pain on my right side. I'm kind of down to a few things. I can look at this rib's ability to move in this direction. Is this rib restricted? Or do I have the facet joint unable to extend? Or am I stuck in a right translation? So though it all sounds very complicated, you see that person, and it could be either they're having pain with that motion, or the motion is aberrant. And it's okay, here's a 35-year-old male with a pretty normal spine structure, but he's not moving well through his thorax going to the right. So, and I have this segment. So these restrictions will show up. The easier ones are the ones that are painful when they do it, because it kind of points to the spot where it will most likely be. The other ones will be those people who have other problems with rotation, and these lesions or this restriction is going on, and it's asymptomatic. And now it's buggering up the shoulder mechanics, or maybe the hip mechanics, or a segment above or below it is now hypermobile because they're lacking the mobility at that segment. So some patients are going to find that where it's less obvious, you'll have to kind of screen through these joints to see, do I have the appropriate motion and glide going through there? And is the motion restriction a driver?
Yeah. And it's with rib stuff, guys, like I said, there's a cluster of movement tests that we can do with each of these potential problems. Rib problems, RIB, ring problems, RING, or facet lesions, right? So when we're looking at the rib, for instance, it's going to move with rotation of the trunk. It's going to move with rotation of the head and neck. Now, rotation of the head and neck is a shared movement. It occurs all the way down through the thorax. It should go all the way down to the TL junction if possible. But so that means that the costotransverse joints all the way down through the rib cage have to be able to move. Otherwise, it's going to affect the ability of the head and neck to rotate. Okay, now it gets a little muddied down, little diluted the further down we go in the spine, but it is possible to palpate these things. And the other thing is inspiration and expiration. So if you have a patient that comes in and they say, yeah, I've got this unilateral pain on the right side of my trunk. It's posterior, right? And you ask them, okay, when does it bother you? Like, well, it bothers me with walking, bothers me with backing out of the driveway in my house, and it bothers me when I exercise. So backing out of the driveway, what do we have to do? Got to look over the shoulder, right? When you're walking, got to be able to rotate the trunk. When we're exercising, what do we have to do? We have to deal with oxygen debt, right? So now we have a situation where we have pain with rotation of the trunk, pain with rotation of the head and the neck, pain with inspiration and or expiration. To me, that's pretty definitive. That's the trifecta right there. That's just like, okay, this is a rib problem. And that's good because that gives us three things that we can test for. We can look at how they're able to rotate their trunk. We can look at the movement of the ribs when they rotate their head or neck. And we can look at the movement of the ribs when they take a breath in or out. We look for the one that's dysfunctional, do a passive mobility test to confirm what type of restriction we're dealing with. Is it muscular? Is it capsular? Is it a pathomechanical? Depending on what type of limiting structure we have, and that guides our treatment. Very simple, guys. And I mean, and this should be the way we think about these things for every region of the body. But I tend to think for the thorax, it actually makes it very, very easy because we can put these clusters together that tell us, oh, well, here's what it is. It's going to be a rib problem. Boom, that's what I'm looking for. That's what I'm treating for. Okay, here's this cluster that now I'm thinking it's a facet lesion. Boom, that's what I'm looking for. That's what I'm testing for. Is it a ring lesion? We're going to combine these different movement tests. And again, like I said, we'll talk about what these are kind of lumped together when we get into the lab, when we're going through our examination process. But we can make this very easy. The mechanics, though, we got to understand the mechanics so that we can decide, because we should be able to predict these things, right? So if I have a patient it hurts when they turn to the right side with their trunk, it hurts when they turn their head to the right side, and it hurts when they breathe out, like if they're trying to whistle, for instance, something like that, or blow out a candle, that would suggest that it's an anterior medial lesion on that right side, right? Can't turn to the right, can't turn to the right, can't expel all that air as the ribs would compress and go anterior medial on either side. So I should be able to predict those things when I'm going through the examination process. And patients love that sort of stuff. When I say, well, here's what I'm thinking, this is what I expect to see going through the examination process, and check one off, check two off, check three off, there it is. They look at you and they say, well, how did you know that without even doing anything? Well, it's because I knew the mechanics and I know what should be affected based on those mechanical involvements. You do that sort of stuff too, Dave? I'm pretty sure we've talked about this in the past.
You get a sense of where the vector is and where it's coming from. And so you'll say, okay, this is coming from the CT junction or upper thoracic spine when you look at rotation. You can kind of predict what it's going to be. So you can talk them through it of here's where I'm going to go. And I use that a lot too, because it's great for patient buy-in. So they know that, okay, I have a concept of what's going on, the problem with you, I'm going to test it. And I walk them through it. You get a lot of buy-in. And that's important too, because you're going to fix their pain in these cases sometimes relatively quickly. But then it's getting that buy-in. Okay, I want you to stick around a little bit for the rehab portion of it. When your pain may not be quite as acute, it's reoccurring. You need to work on, stability in these mechanics.
Yeah. And like I said last week, guys, the thorax, maybe I said this 2 weeks ago, but the thorax is notoriously stubborn. And it's because of posture of the thorax. It's because of the inspiration, expiration, right? We take so many repetitions with the ribs here just for those movements that we're going to talk about here in a second. And when they're dysfunctional a lot, right? If we're an overhead athlete and this is what we do, we can develop abnormal movement patterns because of the mechanics of the shoulder. Something that might be going on where we have a stiff CT junction segment, or we've got a old traumatic arthritis of the AC joint. It's going to limit the mobility of the shoulder, right? It's going to affect the mobility of the shoulder. That's going to force us into a compensation. The body gets used to those compensations the more often that we work with those impaired mechanics. But we can always tell a patient, let's not throw for a while we get these mechanics corrected and we can re-educate these movement patterns. It becomes much easier for that because we can just say, don't do that. With the ribs, we can't do that. We can't tell a patient to stop breathing, right? Because they're going to continue to have these abnormal mechanics because like I said, it's an innate human function. We've got to be able to breathe. So there's no way for us to stop those abnormal mechanics when they have these dysfunctions. They're going to continue to perpetuate. So that's, again, I think part of the reason why the thorax can be so stubborn and so frustrating for therapists is because we treat it, we think, oh, we got this thing, this was a great correction, I did a perfect manipulation, we retest their movement, everything looks good, they're moving really well, and they come back 3 days later or a week later maybe, and it's all jammed up again, and you're sitting there going like, what did I miss? A lot of times you didn't miss anything. You look back, you think back to your reassessment, you're just like, everything was doing so well, everything was moving so well. You can ask Dave, this happens to me all the time. I have patients come in, they can barely move 20% of the amount of rotation that I'd expect them to. One manipulation, maybe two manipulations, and they're doing, full excursion, almost 90 degrees of trunk rotation. And it's just like, it's impossible that I didn't get what was limiting them, right? Had to have gotten it. But then they come back a few days later and it's right back to where it was. I do think that posture and the inspiration, expiration biomechanics are the primary culprit for this sort of thing. We can have instabilities, right? We can have an unsound segment that's going to be relatively lax and it's going to have the potential just kind of slide off the rails again. But I do think that these functional tasks, things like breathing, things like posture, they play a huge role in reverting these corrections that we've made in the thorax back to these problematic spaces, and that will jam them up again. So it's our job as therapists to find ways to kind of maintain that sort of stuff. And like I think I mentioned last week, we'll talk more about kind of the rehab process as we get into the actual lab components here, but it can be frustrating. And I do think that inspiration expiration is a big reason for that.
Yeah, it's like that could be easily overlooked with inspiration, expiration, right? And the postural habits. That's where the movement pattern retraining. And sometimes it's making sure they're moving enough. If they have classic patterns, they do a specific sport. They are a distance runner, or they're sitting all day, for work. They're gonna have certain patterns and characteristics which they're gonna think, okay, we need to have you out of these patterns and moving in different ways to prevent this resubluxation, or also get the neuromotor system just to retrain itself. So it just doesn't regress to the familiar. Like, here's my normal toning pattern. That's what they see in the literature when you see, okay, what are the classic patterns in the upper cervical spine? They take a while to retrain. Manipulation does reset them for a period of time, but given your habits, those postural toning patterns tend to return. So they both need to be addressed. And this whole concept where we talk about subluxation, Eric, you probably see just as many hypermobilities or compensatory rotations in the thoracic spine compensating for another region, or even as much as you'll see subluxations.
Yeah, it just happened to me the other day. I was looking at my stepfather. His back had been bothering him. He had, there were some thoracic components, but it was mostly pelvis pain. But it was being driven by a ring lesion in the thorax. And so I was looking at him and, asking him to rotate, and he can't turn at all to his right side, just totally locked up. I asked him to turn to the left so we can compare, and it was limited also, based on what I'd expect to see. So, but I would say, turning to the right, he's limited almost 80%. It's just totally locked up. Going to the left, though, it's probably limited maybe 20%, maybe 30%. And so I'm looking at him, kind of going through the specific levels and doing some testing, and I'm like, okay, he's got a pretty substantial subluxation at T6, right? He's got a ring that's just shifted completely off to the right. So when he tries to turn to the right, it can't produce left translation. And so it totally binds him up, completely eliminates any movement from T6 down, going to that side. As I'm going through, I see he's got another segment down about T10 that's completely the other direction. Now it's down lower, so we get more out of the spine coming down to that sort of segment. But when I'm testing the segment, there's some translation available there. It's moving, up at T6, I move that. It's not doing a damn thing. It's totally stuck. So what I did is we laid him down, manipulated T6, retested that glide. It was good. Right rotation is back to normal. It's totally full. Perfect. Look at left rotation. It's also back to normal. And I didn't even touch the 10th thoracic segment, the one that was shifted over that way. So what it was doing, it's compensating for that shift here. You have a shift that's taken me this way. Well, now I've got another shift down below that's taking me back the other direction. You correct the driving mechanism, the victim down below, or the secondary compensation issue, self-corrects itself, which is great. We love that. Happens in the pelvis all the time. It's the same deal. You know, the T6 issue through that iliocostalis was pulling up on that side of the pelvis. That's why he was getting that pelvis pain. Fix the T6, the tone dies down very quickly, and it allows the pelvis to drop back where it needs to be. Allows better form closure of the pelvis, and all of a sudden we're doing pretty well. We're not getting this grabbing pain when he puts weight on it or rolling over in bed. Works great. But again, compensatory changes. We see these sort of things all the time. So let's get this stuff, at least these mechanical things, done here. So cage motion characteristics. This is actually, I think I screenshotted this and took this direct out of Gail's material. So I think you guys should have at least something similar to this somewhere in your course materials. But good to kind of look at this from a perspective of upper versus lower ribs. So when we're looking at this, if we're looking at the costotransverse articulation, right? So this is transverse process and the rib tubercle, right? So in the upper portion of the rib cage, the transverse process articulation is much more concave. It's deeper, right? And then we have a significant convexity on the rib tubercle to articulate with that. This is to provide stability, right? If we had a situation where a force load came down on the top ribs here and we had more of a planar joint, we could significantly cause a very significant dislocation of those upper ribs. So much more stable here with these deeper articulations where they almost seat in there, kind of relatively similar to a ball and socket sort of articulation. It's not quite that deep, but it's pretty close. So that's good for stability. It does also affect the movement of the ribs relative from the upper rib cage to the lower rib cage. The lower rib cage, we're going to have a much more planar transverse process articulation, and it's still a relatively convex rib tubercle. This allows for more three-dimensional movement, right? So we're going to get posterior, lateral, and then some inferior gliding with inspiration, expiration, and motions of the trunk. Okay, so relatively speaking, that means we should get greater expansion of the lower rib cage with things like inspiration, right? But it's also going to be less stable. So more potential for rib lesions in those sort of general vicinities as those orientations of those joints tend to transition, right? So we're looking at first rib, second, third, maybe even the fourth, having a deeper, more stable costotransverse articulation, going to have more of this pump handling type of movement, right? So if you're up against my vertebra here and I take a breath in, this is what should be happening, is I should be moving more in the sagittal plane. As we start to move down the spine and we get more of these planar movements, we're going to get more of this bucket handling type of movement, right? Where it's going to create more expansion, relatively greater mobility between the transverse process and the rib tubercle. Okay, so that's an important thing, because when we have dysfunction of the upper thoracic spine, so particularly the CT junction region, T1 through T3, if I have difficulty taking a breath in or elevating the front ribs here, because the front of the ribs here, the sternum, the manubrium and the sternum, it's probably because I can't extend the vertebra in the back, right? So I take a breath in, the vertebra should relatively create a posterior roll extension of the facet joints. If I have a facet joint that's stuck in flexion and I try and take a deep breath in, that thing's not going to go down very well posteriorly. The facet joint won't. And so what we'll get is we have to get a compensatory movement of the upper ribs, right? Still got to expand the chest wall, still got to create that negative pressure gradient where it's going to suck that air in and fill the lungs. But if I can't get the movement here, what we'll see is we'll see these compensatory movements where the upper ribs now will be producing a bucket handle moment. That's because now all of a sudden we've got the scalenes kicking in here to pull the ribs up laterally in order to expand that chest wall and increase that volume of the thorax. So see this a ton. Patients will come in complaining of, lateral neck pain, it's all right here. And usually when we're looking at, neck pain that's related to the spinal segments, they're pointing back in this general area. They'll have reference into the shoulder, or maybe the upper limb, something along those lines. But these ones that they're talking about over here on the side of the neck, that's most likely going to be the scalenes. And the most likely reason for that is going to be upper thoracic dysfunction. And we should be able to assess that very easily. Just drop our hands right onto the ribs and you just say, take a breath in. What we should see is this sort of thing, where the rib tubercle on the posterior element will drop inferiorly, and the anterior portion of the ribs will rotate in this sagittal plane, right? What we'll get instead on the other side is we'll get this sort of thing, where the tubercle will elevate, the ribs will expand laterally, and we'll just say, okay, that seems to be the problem segment. We can kind of do some examination there. Like I said, some passive movement tests, decide what the actual problem is, find our infield, what type of restriction it is, and we can go right into our treatment. It's relatively simple stuff when it comes down to that. But important to know those orientations in order to make sure that we can think through those processes. Anything there, Dave?
Yes. That's what I'll see too. Like, you're dealing with neck or scalene issues. I mean, that's really, I'm going thoracic spine, cervical spine first to clean up the mobility, or how is the system moving? I want to know the motion state of the upper ribs, the CT junction. Where is that pressure being put on the system? I think that's what you'll commonly find. If you get in here and if somebody's focused on the scalene, it's like I have to sort that out first, and then you have the attachment to the transverse process of the cervical spine. So I also want to know what's happening more proximal. So that anterior, that lateral neck pain, rarely do I have to go in there and actually needle or do anything specific musculoskeletally there. I can clean it up, 90% of the time by cleaning up the thoracic and cervical biomechanics.
Yeah, 100%. And it's not that you can't use needling as an adjunct, right? So if you have somebody comes in and that's their pain spot and they're saying like, yeah, it hurts right here and it's bothering me, and like, can't do this, can't do that. But we'll see this all the time, where if you have those scalene issues, what it'll do to that side of the cervical spine, because it attaches to those transverse processes, is it'll compress those transverse processes together. So when I go to try and produce like a side bending moment, or do a pivum or a pavum, like a simple side glide of those segments, they all feel jammed. They all feel like they're completely jammed up, and it's just because that muscle tone of that scalene is just it's kind of locked the whole spine up. So at that point, it's just like, well, I have to go fix the thoracic spine first, just so I can assess to see if there's anything in the cervical spine. Because right now I'm getting lied to. The muscle tone is lying to me. And if I can't get to the point where I can actually assess the mobility of those segments, I don't know if there's a hypermobility and instability or 10 subluxations in there. So I got to get that muscle tone down. So a lot of times I'll do that, where I'll go in and I'll treat the upper thorax, and maybe even have to do some needling or some sort of release technique into those scalenes to get them to relax, get them out of the way. And then I can go in and do a more specific assessment of the cervical spine, because now I don't have that muscle tone in there lying to me about it.
Yeah, that's important, of like even doing like the pivums and pavums and checking anchovertebral joints like we did in the last course, because you get a sense of, okay, I have multi-segmental compression. So either this person is, are they 72 years old and it's all ankylosed and arthritic? If it's a 34-year-old female, then I know that, okay, what would cause that? And that would most likely vector would be the muscle tone.
Yep. So this is the last little thing here, guys. Mechanics of inspiration, expiration. We were talking about this a little bit previously, but when I take a breath in, this is a nice little graphic here. So the one thing I want you guys to take notice of is the angle here of the transverse process, right? So this on the right here, this is an upper thoracic segment, where relatively speaking, the transverse process is closer to a 90-degree angle with the vertebral body. That's going to produce more of this anterior vector here, where we get movement in the sagittal plane. Okay. Relatively less gliding occurring at the costotransverse process, costotransverse joint. This is more of a pivoting moment right here at this point, as opposed to this vector that goes along that line. If we take that down and now we're looking at, maybe the 8th rib, something like that, all of a sudden the transverse process angulation with the vertebra is significantly more posterior, right? And so now we have this vector with the costovertebral joint and the costotransverse joint. That's going to alter our mechanical line of movement to this more lateral expansion, right? So this is going to be more of that bucket handle type of movement where we're getting more gliding occurring across this moment, right? And so these are very similar. We're going to have these sort of posterior lateral or anterior medial type of moments that will occur at these segments, okay? Particularly more noticeable as we move further down the spine, right? So if we move out of those top 3 segments, get into the 4th, 5th, and then down through at least the 10th segment where we have costotransverse joints, we're going to see these sort of things. So when I take a breath in during inspiration and the rib cage has to expand, right, has to get bigger, we should get this posterior lateral translation along the line of that costotransverse joint, okay? Conversely, when I exhale, we should get a compression of the thoracic cage. So relatively speaking, this anterior medial translation of the costotransverse joint. Now, this is Earl Pettman stuff. He's very strict on this sort of thing. It occurs also during rotation of the head. But he proposes that these posterolateral anterior medial glides are what are lost. This is the problem. This is what is lost during with lesions of the ribs, right? So we should be able to assess for these things and make it more diagnostic for whatever lesion that we're dealing with, right? So
describe the reference point of the anterior medial glide. Like what segment? Because I think it's confusing.
So if we're looking at movement occurring here at the costotransverse joint, right? So if I breathe in, right? So if I take a breath in, what should happen is this whole segment should expand, right? It should produce this sort of moment, which would go posterior and lateral in this vector along this X line here. So that's a posterior lateral glide occurring here at that costotransverse joint. If I breathe out, right, so if I exhale, it should be the reverse of that. The rib cage should compress down. And so what we should get is this glide relative along the same line, along the same vector here. It's just in the opposite direction. Now, there is some inferior movement that occurs when we take a breath in. It's going to be kind of posterior lateral and inferior, and then it's going to be anterior medial and superior with exhalation. But we don't tend to have to, especially in the lower thoracic spine, we don't have to worry about that inferior or superior moment. Particularly, it's more the anterior medial or posterior lateral glide that we have to concern ourselves with. And again, like I said, we get this same sort of movement with rotation of the trunk. We get the same sort of movement with rotation of the head. And then we get it with inspiration and expiration. So we can use those 3 things to determine, is a particular rib not producing one of those movements, anterior medial or posterior lateral. And then we can use a PIVM, PAVM, so basically a passive mobility test to determine what is it that's causing this restriction. Is it muscular? Is it connective tissue capsular type of restriction? Or is it a hard pathomechanical sublux type of end field where we're going to need a manipulation to correct these things? Because that will drive our treatment technique. If we have an end field that feels muscular, I'm not going to manipulate that, because what's most likely to happen? I'm going to run into the muscle, and either I'm going to damage the muscle tissue, or I'm going to damage the joint, or I'm going to run into some sort of spasm and I'm not going to get past it. If it's capsular and I try and manipulate that, a pretty good chance that I'm going to end up tearing through that joint capsule, and that's going to cause additional problems, up to and including some sort of traumatic arthritis. So that's going to require more passive mobilization as opposed to a manipulation. But if we run into that pathomechanical end field, now we're free to do a type of manipulation. So end field, those passive mobility tests, those are essential for us to determine what type of treatment we're going to do. But that's essentially the thought process that I use here, right? This inspiration, expiration, posterior lateral versus anterior medial, and it has not led me wrong in the last 15 years. I've been using this type of thought process.
Yeah, this is this is the accepted model with everything's a model, and it's hard to prove these things. This will serve you well. I sent out the article that was written. It's probably about a few years old now that Diane Lee wrote for, I think, it was in manual therapy, I believe, and she just goes through these biomechanics and describes them. So these pictures would be in that article. And I also sent you 2 videos of basically the thoracic palpation that she does with a skeleton, just landmarking and going through, and she'll talk about these joint mechanics. They're in the curriculum in the book section to prepare you, but I emailed them out just so it kind of jar you in case your head is spinning a little bit, and we'll look at it on a skeleton.
Yeah, and we'll do probably one of the first things we do after a review of modules 1 and 2, when I get there in a couple of weeks, is we'll do some surface anatomy palpation. So it's good to be able to see it and get